Welcome, everybody, to this GHAPPcast. My name is Patrick Horne. I'm a nurse practitioner at the University of Florida in Gainesville. And with me today is Jordan Mayberry, a physician assistant at UT Southwestern. And we're going to be talking about diagnosis and management of cirrhosis today. So, Jordan, thanks for joining and happy to have you.
So excited to be here.
So, want to start off with, if I can, just ask you, for you in your practice, what are some key diagnostic tools that you use to diagnose cirrhosis?
In my practice, we use a number of things when we are diagnosing cirrhosis. We will look at laboratory values. So we're going to look at those liver enzymes to see if there's any active inflammation within the liver. We're also going to look at things like the albumin and the bilirubin and the INR to determine how the liver is functioning. We can look at the platelets. So platelets are always a good way to kind of to detect early cirrhosis. So if we're seeing any evidence of thrombocytopenia, it's kind of a red flag that we really want to evaluate further for the possibility of cirrhosis. So we're using labs. We're also using physical exams. So we're looking for any evidence of decompensation. Did this patient come into your clinic with ascites or lower extremity edema? Are we seeing spider angiomata? Are we seeing palmar erythema? So physical exam, of course, is very important in these patients. And then imaging. We can use a lot of different imaging modalities, things like ultrasound to see if there's any evidence of nodularity within the liver. Do they have any evidence of small ascites on imaging? So really a number of things that we are using to diagnose cirrhosis.
Yeah, I think I'm pretty similar, and I would assume this is pretty consistent. A lot of my patients that come to me labeled as cirrhotic, may have had like an ultrasound or even a CT in the ER for some other reason or something. And like you said, there's a cirrhotic appearing liver. Maybe there's some splenomegaly. Maybe there's some ascites or signs of portal hypertension. I completely agree with you. Platelet count, especially, I think that's always one of the ones I go to first and look at is if I'm seeing a low platelet count, especially over a significant period of time, I've got kind of a high index of suspicion for cirrhosis for sure.
Yeah, I think it's important to remember that there's no one single test, right? We do use all of these tests in combination. So we can't necessarily diagnose cirrhosis with just labs alone. Imaging is pretty good, but I think it's not a perfect way. I'm sure you've had some patients that have come in kind of frantic because they've had imaging done and incidentally found cirrhosis. And then after we do a further workup, maybe that wasn't the case. So no single test for diagnosis of cirrhosis, but just using a combination of both test and physical exam and history can be helpful.
Yeah, I completely agree with you on that. What about liver biopsy? Do you still utilize liver biopsy in your practice?
Yeah, we do occasionally. And I think that as most people may agree to, but I think that this is the case, is that we are using liver biopsy less and less. We have some really good non-invasive tests that are now available that we don't need liver biopsy in the way that we did previously. In our practice, we're using liver biopsies for those patients that we don't have a clear diagnosis. So if you get the full chronic liver disease workup and we just still don't have a clear understanding on why those liver enzymes are elevated, then the liver biopsy may be helpful. Some clinical trials for our MASH and MASLD patients require liver biopsy. So there is still utility for liver biopsy, but I would say that we use it less than we did when I first started practicing.
Yeah, no, that makes sense. And we're going to kind of lead into the next question around non-invasive testing. But where I utilize liver biopsy a lot is, and I think you alluded to it, is when sort of those non-invasive tests are either inconclusive or are suggesting, maybe one thing or another, but it's just not 100% clear. Sometimes a liver biopsy can really help kind of clarify that. So, leading into that with non-invasive tests, and you had kind of mentioned it, that we're using them more and more in practice, and I'm sure that's universal. But what particular non-invasive tests do you guys have at UT Southwestern, or what the ones that you utilize the most?
Yeah. So As we're working up these patients to determine whether or not they have cirrhosis, staging of their liver disease is very important because dependent on the stage, that will tell us how we are going to follow these patients moving forward. So in some way, shape, or form, we have to stage. We have to determine whether or not this patient has advanced fibrosis or cirrhosis. So there are some really great tools to help with that. No test is perfect, but we do have a lot of very, very good tests. In our clinic, we use FibroScan. So we have a FibroScan, and all of our new patients should receive a FibroScan at the same time that they have their first visit. So FibroScan is an elastography modality similar to that of ultrasound elastography. So those are two modalities that we can use for staging. In addition to that, we calculate a FIB-4 score, which is calculated with blood work. And then occasionally we are able to order the ELF score as well, which is another serum marker to evaluate for fibrosis within the liver.
Do you guys utilize MR elastography, or do you have access to MR elastography at all?
We're very fortunate that we do have access to MRE. And in Texas, we seem to get pretty good coverage for MRE. I don't run into too many instances where I can't get coverage for MRE. We will use MRE kind of as a secondary staging. So once we have done the FibroScan and we have done the serum markers, if we have discordant information, then we would move forward with an MRE to evaluate for stage of fibrosis.
Yeah, that makes sense. That's very similar to, I think, how I practice as well. So when you find a patient with cirrhosis, let's say they have decompensated cirrhosis, for example, what are sort of your screening strategies, or what are the things you educate the patient and the family on to look for, or what are you looking for in your initial visit of a patient that recently has been diagnosed with cirrhosis? What does that look like to you?
So the most common complications that we see of cirrhosis are fluid overload. So these patients that have ascites or maybe even lower extremity edema. Jaundice is another complication that we're monitoring for. Esophageal varices, hepatic encephalopathy, and then we should be screening these patients for hepatocellular carcinoma. So at initial workup, we are looking for any of these possible complications, but also asking about history to understand if they've ever experienced any of these complications. Has there ever been any vomiting of blood? Have you ever had fluid on your abdomen? So those are the initial complications that we're looking for.
Okay. And then once you've got an established patient now, and so they have cirrhosis, and you're seeing them every however many, every months or whatever within clinic. What are some of the ways that some of the things you talk to the family members, or how do you monitor for complications sort of cirrhosis in between those visits?
Yeah. So I think education is really important here. We should be educating all of our patients on what the possible complications of cirrhosis are. This way, if they experience any changes in their health status, we are one of the people that they call. So if they notice that they're gaining, 5 pounds over a 24, 48-hour period, that is not normal weight gain. So please reach out to us if you see something like that. So education is really important. We also can use things like endoscopy to evaluate for esophageal varices. Now, how we use endoscopies for screening for esophageal varices has changed, and that's where our staging modalities come into play. So we can use things like FibroScan and their platelets to determine whether a patient needs an endoscopy or if we should be considering medication in that patient population. And then, of course, we want to make sure that our patients are getting their HCC screening. So these patients should have some sort of imaging and an AFP every 6 months to evaluate for HCC.
Yeah. Any lifestyle modifications that you talk to your patients about, or cirrhotic patients in particular?
Yeah. Of course, it depends on the etiology of their cirrhosis. So that's really important as providers for us to understand what has caused their cirrhosis. So alcohol, MASH, viral hepatitis, we definitely want to make sure that we are treating with medication anything that we are able to treat. So if this patient has autoimmune hepatitis, if they have PBC, we want to make sure that they're on appropriate treatment. If the patient has viral hepatitis, we also want to make sure that we are either treating and curing their hep C or determining whether or not their hep B needs to be treated. For all of our patients that have cirrhosis, I always say to my patients, once you have one liver disease, we don't want you getting another. So it's very important that they are modifying or having alcohol use and limiting alcohol use. It's also important that they have healthy lifestyle. We don't want these patients developing MASH or causing their MASH to worsen. So healthy diet and exercise, we're recommending a Mediterranean-like diet. They should be getting cardiovascular and resistance exercise. And then I also say, if you're a coffee drinker, that's probably a good thing. There's some data that coffee can also help with inflammation within the liver. Now, the data is not strong enough if you hate coffee or if it causes anxiety that you should be forcing yourself to drink coffee. But I say if you're a coffee drinker, maybe feel good about having that second or even third cup of coffee in the afternoon, because that may be helping your liver as well.
All right, perfect. Well, thank you, Jordan, for joining us today. I think that concludes this GHAPPcast, and thank you all for joining us as well, and have a good day.